All right, I think we're going to go ahead and get started. Welcome, everyone. Thank you all for joining the G6PD Operational Research Community of Practice webinar. And today's webinar is on early experiences with point-of-care G6PD testing and malaria case management. And we'll be having 3 brief presentations from groups each from Laos, Vietnam, and Cambodia. So before we get into today's presentation, I'm just going to go over a quick agenda. I have a few webinar logistics. We'll speak a bit to the GORCoP, and then we will go ahead and begin our presentations, followed by a questions and discussion period. So for those who may be new to the G6PD Operational Research Community of Practice, or GORCoP, I just wanted to highlight that we do have a webpage for the Community of Practice, which can be found by going to path.org/GORCoP. There you can find more details as to what the Community of Practice is, but in short, it is a collaboration of researchers, organizations, malaria control programs, and clinicians committed to advancing the introduction and scale-up of G6PD diagnostics in support of safe access to radical cure treatment for P.vivax malaria through operations research. So in this group, we're really trying to harness best practices and lessons learned from experiences others have, and to support information sharing. The GORCoP maintains a digital central repository of resources that is accessible to all participants and members. We hold meetings and webinars such as these ones, and provide ongoing updates, and we really aim to create connections among our participants. So please feel free to access that website at any point for additional details. Feel free to join if you're not yet a member, and follow up with any questions you may have. So with that, I'm going to pass it on over to our moderator, Spike Nowak, to quickly share about the P.vivax Operations Research Database, and then we'll move into tonight's presentations and let our speakers introduce themselves. There will be opportunity for Q&A at the end, where you can raise your hand in the chat function or type out and submit your question directly through the chat, and Spike will be able to moderate those coming in. So Spike, I will hand it over to you now.
Thank you, Amanda. And thank you everyone else for joining today's GORCoP webinar, no matter where you are, if it's morning, night, or afternoon. So before we get started, I just wanted to also draw some attention to the P.vivax Information Hub. On that website, you will find a database of current efficacy, effectiveness, implementation, safety, and operations research studies, focusing on improving access to safer radical cure for P.vivax malaria. These are studies that are either in preparation, ongoing, or have been recently completed. And this database aims to identify what research is currently being planned, so that gaps can be identified, support evidence for informed decisions for P.vivax malaria cure policies, and to help researchers in national malaria control programs and implementers make connections to increase efficiency and accelerate access to safer radical cure. Now, today we're going to hear 3 talks from speakers in Laos, Vietnam, and Cambodia. First, we'll hear from Laos on an operations research study, then in Vietnam an operations research study, and finally from Cambodia, where they're rolling out G6PD devices for routine use. So again, a reminder, try to keep your comments for the presenters around 10 or 12 minutes so we can leave some time for questions at the end. And looking forward to the questions from the audience after this. So first up, we'll have a talk from Laos with Dr. Vieng, the head of SIMPE, also Dr. Keo Bopopon from SIMPE as well, who's the head of the case management unit, and then Sinkeo and Sarah from UCSF, who are working on the operations research study there. So with that said, Sarah, I'll give it over to you.
Yeah, thanks so much, Spike, and thank you for organizing this for us to share this vital information. So I am Sarah, and I'm a program coordinator with UCSF, and here we also have Dr. Keo Bopopon from SIMPE, and Sinkeo Vieng, and Tim is also here listening in from UCSF. Unfortunately, Dr. Vieng couldn't join us unexpectedly, so he won't be here. But yeah, so we're gonna just give a brief overview of our operational research study here in Laos that focuses on G6PD, quantitative G6PD testing. We can move on to the next slide. So yeah, so we have two parts of this study, kind of. We have a nested part of a bigger study called COMBAT, which is a clustered randomized control trial. And we have quantitative testing at 11 health centers in Southern Province in 5 districts. We also have a separate path study, which is a prospective intervention study. And there we have quantitative G6PD testing at 3 district hospitals in Southern Province in Samoy, Taoy, and Tublan. So we started study implementation in August 2020, and it will likely continue until September 2021. I just also wanted to give a brief overview of the current guidelines that we have for PV treatment. So they have qualitative testing at district hospitals and at select health centers, high burden FTET health centers for males only. And then other places, it's just 8-week PQ for all women without testing. Can move to the next slide. Okay, so in terms of our study objectives and outcomes, so our main objective is to determine the operational feasibility and safety of conducting G6PD testing and administering PQ and follow-up at a community level, so both at health centers as well as the district hospitals. And we're also looking at different factors associated with G6PD testing and PQ treatment and subsequent adherence to PQ. And an additional thing is looking at the capacity of the health workers to implement this testing at a health center level. And in terms of primary outcomes, we're looking at the proportion of confirmed PV cases that receive quantitative testing prior to treatment. And we're also looking whether they're receiving the correct treatment based on G6PD results and any severe or adverse events that occur. Move to the next slide. In terms of training, so we adapted training materials that we were provided by PATH, and we had both theoretical and practical sessions. So we trained 47 individuals at multiple levels. 4 SIMPE members were trained, one provincial member, and 5 district level malaria staff. And then at the district hospital level, we trained a total of 15, and they were a mix of lab technicians, physicians, as well as the director of the district hospital. And at the health centers, we trained 2 health center staff per facility, so it was a total of 22 health center staff. During those trainings, we had 3 trainers for both the DH and the district hospitals and the health centers. So they were 2 separate trainings, and our average trainee to trainer ratio was 22:3 for health centers and 15:3 for district hospitals. In terms of impressions from the training, the main impression was that the district hospital staff were able to understand the steps and the interpretation of the G6PD results a bit better than the health center staff, which was expected. And this was demonstrated by their successful first attempt at the testing procedures. They did note that in terms of the steps involved in the QC, there were quite a lot of steps involved, and that the qualitative test was easier to use. But that said, that the quantitative tests provided easy to interpret results for both G6PD and hemoglobin levels, which hemoglobin we didn't have with the qualitative. In terms of lessons learned, we would have liked more time and study supplies for the health center training for them to practice using the test. And also we noted that the same easy tube was used quite frequently for both the mixing and the sample collection. Can move to the next slide. So after the trainings that we had in June and July, we delivered the equipment and did a refresher training in August. So both SIMPE and UCSF visited all our study health facilities and distributed the supplies. Each facility was provided 1 G6PD analyzer kit, 1 box of test devices, and 1 box of controls, as well as any data collection and consent forms that were needed for the study. And the main thing in the future is to have less time between the trainings and the implementation of the study, so that we won't necessarily have to conduct refresher training, because that lapse in time makes it more difficult, as the health center staff might forget the different steps involved with the testing. So we had a total of 20 G6PD analyzers. 70 boxes of test strips and 60 boxes of controls. Move on to the next slide. In terms of quality control, we had planned for weekly, but in reality, they've only really been run during trainings, during supervision visits, and during QA, which were G6PD assessments. Simply in the context of our study, would have preferred weekly controls, but it just, because of the workload of the health center staff, as well as figuring out when to run them exactly, that really hasn't happened. So the control runs are being recorded on the quality control forms, and the ranges that we're using for the controls were provided by path, and you can see them there for the different controls, level 1 and level 2. In terms of findings, we have, as I said, difficulty figuring out the appropriate time to run the controls, whether to do it right before the patients are treated, especially in settings when we don't have that many cases, and then thinking about how frequently. That's something definitely we need to figure out in the future. So we also had several units that failed control runs, and they were all level 2 controls with hemoglobin levels falling below the range, below the expected range. And this happened specifically in one district hospital and 2 health centers. Can move to the next slide. In terms of G6PD test interpretation and decisions, so we have male and female differentiation. For males, we have normal and deficient, and for females, we have normal, deficient, and intermediate. If their G6PD level is lower than 3.9 for males, they're deficient and they get the 8-week. And then if it's over 4, then they get the 14-day in our G6PD normal. For females, we have the 3, and if they're intermediate and deficient, they get the 8-week, and then normal is over 6 for females, and they get the 14-day in that case. In any case, if the hemoglobin reading is under or equal to 8, then PQ permacrim is not provided. As part of the study, at the health center level and not the district hospital level, we're doing follow-up by village malaria workers, and this occurs on day 3, 7, and 14 for 14-day PQ treatment, and for 8-week it happens once a week for 7 weeks. During these visits, adherence to treatment is recorded, both reported and in terms of packet confirmation. We're also recording the occurrence of side effects, dark urine, heart palpitations, shortness of breath, that list that is there. If they find dark urine, heart palpitation, or shortness of breath, they're immediately referred to the health center and then to the district hospitals. Move on to the next slide. So here's just a brief overview of our outcomes so far and distinction between combat and PATH district hospitals. So in terms of the proportion of confirmed cases that received quantitative tests prior to treatment, we have 14 out of 17 at health centers and 4 at district hospitals. In terms of the proportion of cases that received the appropriate treatment at health centers, we have 13 out of 14, and at district hospitals, we have 4 out of 4, and we have no occurrence of any adverse events. Can move to the next slide. Here we have a bit of that same information in addition to a bit more of more detail. So again, we have the number of cases that were tested using G6PD tests, 4 at the district hospitals and 14 at the health centers. And then in terms of normal versus deficient, most of all our cases were normal. There was only 1 case that was deficient at health center level, and then 1 we weren't sure yet about the status. And then in terms of follow-up cases, we can see we have followed up 17 out of 15 cases. So we can see that their follow-up is quite difficult to implement. And the number of failed QC runs, that's what we discussed earlier. There were a few all at one district hospital, and then 2 at 2 different health centers where we had some failed control runs. We can move on to the next slide. So experiences and challenges with G6PD tests. The main ones are the following. There's short shelf life of G6PD test strips. Given the length of the import process into Laos, which takes about 3 months of the 12 months shelf life. So that's quite difficult. They're in an elimination setting where we don't have too many cases. There are too many test strips per box, which means that, since we can't split the boxes up, it makes it we don't end up using all of the supplies, using them effectively at least. And then if we're gonna run the QC fairly often, then there really isn't a sufficient number of easy tubes per box for both the tests and running for patients. And then we also have an issue of poor quality batteries. And then in terms of study implementation, that question of finding a time to run the controls. A big one was ensuring the date is set on the unit so that we know if we need to go back and there are holes in data reporting, we can just go back to the tests and check the date and the time to see if it matches and fill in that data if it's missing. So that was an important one. And yeah, just to mention again, the patient referral from VMWs to health center for testing can also sometimes be incomplete, as well as treatment follow-up. So sometimes the patient doesn't get referred directly from the VMW to the health center because they had prior plans to travel and they just end up traveling instead of going to the health center for testing. And then we also did baseline health facility G6PD skills assessment. We're still reviewing that data, but we conducted assessments on all district hospital and health center staff to assess their level of conducting these tests. So yeah, next slide is pretty much, those were our key findings. So thank you. And yeah, let us know if you have any questions.
Thank you very much, Sarah. That was great. So thank you, Sarah, Dr. Kao, Tim, and Sinkeo. We'll take questions at the end. So if you have any questions, write them down now, and eventually there'll be a part where you can raise your hand and then you can voice your question. So now I'd like to hand it over to Huynh Nguyen from PATH to talk about an operations research study in Vietnam that PATH is doing along with NIMPE. Dr. Gonzalo Domingo and Dr. Huy Quang Phuc are both working on this together with us. So Huynh, I will hand it on over to you.
Yeah, thank you, Span. And hello, everyone. My name is Huynh Nguyen, and I'm working at PATH. And I'm today on behalf of Vietnam team and also NIMPE College, including Dr. Phuc and Dr. Mai from NIMPE. I would like to present some experience from the operational research on G6PD test in Vietnam. Next slide, please. So our study is a prospective interventional study, and it is conducted in two provinces with a very high burden of malaria in Vietnam. And you can see the location of two provinces in the map on the right-hand side of the slide. And in each province, we select 1 to 2 districts to conduct the study. And in each district, we select 1 district hospital and 2 community health stations where malaria patients usually visit to get treatment to conduct the study. So in total, we conduct the study in 3 district hospitals and 6 community health stations in Vietnam. And we plan to conduct the study from October 2020 until August 2021. And the data collection will be end in June. So actually, at the beginning, we plan to conduct to end data collection in January 2021. But I think this year, due to COVID-19 and a lot of different reasons, so the number of malaria cases in Vietnam in general is significantly decreased. So we need to extend the study, especially data collection until June 2021. And before our study conducted, G6PD test is not routinely conducted in Vietnam because actually it's not available in I think in all of the health facility which usually provide malaria treatment in Vietnam. Even like the national treatment guideline recommend that if G6PD test available, they should provide G6PD test before prescribing thermocline for patients. Next slide, please. And it is the objective and also primary outcome of the study. So the main objective of the study is to assess the feasibility of integrating G6PD test in the routine case management in Vietnam. And we have 4 specific objectives, as you can see in the left-hand side of the screen. The first objective is to assess health worker proficiency in the use of G6PD test. The second objective is to assess the fidelity of G6PD test and treatment use to prescribe use. The third objective, we want to understand the cost if we introducing and integrating G6PD test in routine case management. And the last objective is to assess the perception of healthcare worker and patient on barriers and facilitators associated with G6PD test for safer radical kill. And we have 4 primary outcomes on training, on competency, on testing, and on treatment, as you can see in the right-hand side of the slide. I will talk more detail about the outcome later in the result part. Next slide, please. And we start our study with training. We conducted 1 TOT training in Hanoi, and then we have 3 training at 3 study sites in Uzamap, in Krongpa, and in Iapa. And in each training, we divide it into 3 main parts. The first part, we will provide lectures and demonstrate the use of tests for trainee. And then we let trainee to practice using the test. And after trainee practice using the test, we test their knowledge and their skill running the test before we decide to provide certificates on proficiency for trainee. So in total, we provide training, full training for 44 participants, including doctors, nurses, lab technicians, and also malaria manager, like for example, malaria specialist. And in each training session, in districts, in Uzamap, in Krongpa, and Iapa, we will have 4 trainers, 2 trainers from PART and 2 trainers from NIPE. And the average trainee to trainer ratio is 3/1. So we have some observation after the training. The first one is we are very lucky because I think our training happens after a lot of training in other countries. So we have opportunity to kind of review and also learn experience from other countries. And in our training and also in SOP, I think we revised a little bit compared with some material in other countries. For example, we guide trainee to use ECTIF to mix control with buffer. It is a little bit different with the guideline from SMIU. They guide trainee to check 20 times to mix control with buffer. The second observation is we think practicing before testing is very important because it's let trainee get familiar with the test and also they're more confident before they conduct the test. But one observation we experience in Vietnam is participants tend to run the test by memory. Even like before training, we print out all of the SOP in A3 paper form and then provide for trainee. They can read the SOP very clearly, but they tend to run the test by on memory, and they don't want to read the instruction. And we need to remind them again and again about that. And I think lab technician and young staff learn quicker than other participants. I think it's kind of expected. Next slide, please. Some challenges we face during the training in Vietnam. The first thing is participants were not really aware about the importance of counseling part for patients. So in the lecture, we provide some kind of like information about how to provide counseling for patients, but my observation is people didn't pay attention to that part. And the second challenge is it's very difficult to seek input to develop quality control procedure, as participants in Vietnam were not really familiar with the similar procedure. And we think if possible, training aside would be better. And if the number of trainees is large enough, we should design training curriculum for each type of trainee. Next slide, please. Regarding quality control, we guide participants in Vietnam to run quality control every month, and in some special case. And for each time, they need to run high and low control. If the results of any high or low control are out of range, they need to run control again. And if the result of the second round are still out of range, they should contact with a focal point admin pair. And they need to record result every time they run the test, even if it is control run or it is the test for patient. And we design a data collection form to record the result of the test, as you can see in the right hand side of the slide. Next slide, please. Regarding the treatment therapy, so it is a treatment therapy according to the National Treatment Guideline in 2020. You can see, I think, different with the National Treatment Guideline in Laos. In Vietnam, we provide 8 week primaquine for deficient patients only. And for other cases, including patients with intermediate results, they should receive 14-day primaquine. However, while we are conducting the operational research on G6PD test in Vietnam, NIPE is also conducting a study on 7-day primaquine. So patients with normal G6PD test might receive 7-day or 14-day primaquine depending on the decision of the doctors. And regarding follow-up, it's not a must in Vietnam. However, in some provinces in Vietnam which receive the I think the financial support from RISE project, they use village health worker to follow up with patients every day. And I think it's very lucky that on site we conduct the G6PD study in Gia Lai and Bình Phước. They got the follow up with village health worker. And another thing is the distributor in Vietnam doesn't have expertise to fix the analyzer. So because they said that the test is very new with them. Next slide, please. So it is some updates about the study status. So for the first outcome, the training, we have 43 among 44 trainees certified as proficient in the use of G6PD test. Regarding the competency, because we haven't conducted the midterm and end-term evaluation, so this result is temporarily similar with outcome 1.1. For the testing outcome, we have 100% of VIVAX case, including mono and mixed case. received G6PD test prior to treatment decision, with result record in the case report form. Regarding the treatment outcome, we got on only 10 among 13 patients receive the radical Q treatment. I would like to explain more about this outcome, because in Vietnam, when patients receive deficiency results, they need in the national treatment guideline, they require that this patient should get the treatment at the health facility with have blood transfusion service. So 3 patients with deficient result in Vietnam, they were referred to to other health facility according to the national treatment guideline. But because that health facility is very far, so patients refused to go to the health facility, and they didn't got any radiotherapy treatment at all. Next slide, please. So for this slide, we just provide more detail about the study, some of the outcome in Vietnam. But I want to mention about, I think, one special case in Vietnam in Buzamba Commune Health Station. So we have 2 patients coming at the same time, and 2 patients are sibling, and 2 patients got deficient results. Next slide, please. And in Vietnam, to ensure that they getting correct results, our procedure as follows. When healthcare worker identify any case with deficient result, health worker will run tests with high and low control and read patient blood one more time. And in the case in Bình Phước that I mentioned earlier, the staff also run the test with blood collect from a healthcare worker to be confident about the test result. And in the study in Vietnam, we observe that monitoring is very important, especially when we start using the test. And refreshing on site during supportive supervision is also important, especially when site don't have a lot of place for some health workers who don't run the test frequently. For quality control, we need a monthly reminder to conduct quality control, because actually health facility in Vietnam, they don't need to run quality control routinely for other rapid tests. And also we experience challenge to refer patients with deficient result to get treatment at health facility with blood transfusion service. Some other recommendation and consideration. The first one is we observe that if the tip of easy tip touch the specimen application hole in the device, the specimen will be automatically withdrawn into the hole, and we don't need to squeeze the tip to withdraw the sample inside. And we also recommend that it would be better if we have more easy tip per box. Next slide, please. And it is some in the next slide. It is some common errors we observed during the study. The first one is I think some health workers forgot to turn on control mode when they run the control. I think one case in Vietnam, they forgot to mix sample with buffer. Another errors is in one health facility in Vietnam, they turn on the Bluetooth mode in the analyzer, and then the Bluetooth icon hide the hemoglobin result, and healthcare worker thought that the medicine no longer work, and they contact the focal point at Ninh Pe, but then the focal point at Ninh Pe figure out that it is because of the Bluetooth icon. I think the next common errors is when people took out battery and they forgot to reset up the date when they turn on the analyzer again. And in one health facility in Vietnam, we observe error 9, communication error with co-chief, and we need to contact. We need to collect the analyzer again, and then provide a new machine for that health facility. I think it's all of the information from Vietnam. Thank you so much.
Great, thank you, Hien. Okay, and now I'd like to hand it over to Yuchin Tsai from CHAI, who will present on Cambodia and work that they're doing with the CNM to roll out G6PD testing. Yuchin, over to you.
Thank you very much, Spike. Hello, everyone. I'm Yuchin Tsai from Clinton Health Access Initiative. We have been working with Dr. Soleil Lake from the National Malaria Control Program, CNM, in Cambodia, providing technical supports for the rollout of P.vivax radical cure nationwide. And our CHAI team also has Evelyn Wong, Tia Som, Bumain Chun, and Dr. Julian Dang here, either based in Cambodia or global supports for this rollout by CNM. Next, please. So P.vivax radical cure has been implemented as a national program from year 2019 with 2 phases of rollout in Cambodia. Phase 1 implementation, CNM used G6PD qualitative RDT and Primaquine 14-day to 88 health facilities in 4 provinces from October 2019 to January this year. The goal is to collect some lessons learned and inform the national scale-up. CNN then rolls out the national scale-up to the whole country using SD biosensor G6PD quantitative test and also Primaquine 14-day for G6PD normal patients, with the training conducted in October, November last year, and some G6PD already distributed out this month. And the implementation looks like we'll start very soon in late June or February. So in the following slides, we will have some key outcomes from the phase 1 radical cure and what have been changed from phase 1 to the national scale up and what we have learned so far for the new G6PD quantitative test. Next, please. In phase 1, the percentage of all PV and mixed cases received radical cure, increasing from the baseline of 0% in the 4 provinces to 30% in October 2020. And some of the gaps and challenges we have observed includes the high drop-off rate of PV patients from the community level, and the phone call follow-up by health centers sometimes is difficult to reach mobile migrant population and also difficult to verify the drug adherence by patient self-reporting. And the flow of side effect reporting could also be strengthened. Therefore, after the implementation of phase 1, CNN and TWG, including WHO and partners, has several discussions and meetings to incorporate some of the changes and improvement for the national rollout, including change from the qualitative RDT to quantitative biosensor, which means that not only males but females are eligible for getting G6PD test. And CNM also included the involvement of the community level, like the village malaria workers and mobile malaria workers, to refer and follow up with patients. We also transited from the paper-based reporting collected by CSO every month to the MIS real-time app built in for both health center and VMW to report the data. And CNM also proactively collaborating with the Department of Drug and Food, DDF, in the country regarding the training and adverse event reporting flow to strengthen the pharmacovigilance in the country for radical cure. Next, please. So this map shows where are the 4 provinces, including in the phase 1, and how is their PV burden. And you can see that the provinces across high burden of PV and lower burden of PV caseload, which is because CNN want to learn more about the barriers and success across different areas with different case burden. In the graph on the right is the data from November 2019 to actually October 2020, a 1-year implementation results showing how many PV and mixed patients in the 4 provinces ending up completely radical cured. And you can see from the second bar to the third bar is actually where the huge gap is. Means that when patients are eligible for getting G6PD test, the percentage of the patient really received a G6PD test is 44%. And this gap of loss consists of 2 types of patients. The first type is when patients were detected by the health facility, but especially in the beginning of the rollouts, when the health facility only have 2 staffs going to the training, when they came back, they haven't started to train other health facility staffs. So a lot of patients come to the health center, and then the health facility staff who have been to the training were not available or went out for other activities if the health center have higher burden. So the patient will just went back home without further testing with G6PD and radical cure treatment. So this has been resolved more and more when health center staff start to do more training to other health center staffs, and the patients loss from this group is less and less after a longer period of implementation. And it also includes another group of patients detected by BMW, since BMW either didn't refer or they refer, but the patient didn't travel to health center. And this is actually a main loss of population, since BMW in Cambodia detect more than 60% of the cases in the country, and the successful referral rates in phase 1 was only about 27%. Next, please. So after all the successes and challenges learned from the phase 1, CNN started to scale up radical cure nationwide to 324 health facilities, including all provincial hospitals, referral hospitals in endemic areas, and the selected health centers with more or equal than 1 PV and mixed case per month. So the training was conducted for 1 day for provincial hospital to manage side effects, and 3 days for all the health facilities that enrolled in radical cure. And for the national scale up, with the support from UNOPS, CNN procured 368 analyzers and 12,250 tests for the whole country 1 year use using Global Fund Right to E budget. And CNN also requested partial of the amounts arrived earlier for the use of the training. Fridges, cold boxes, and ice packs were also procured for every health facility for delivery from the district to health center, and the storage at health center, since a lot of time Cambodia has a temperature over 30 degrees Celsius. Next, please. The technical working group and trainers also share their observations during the training for the national scale up. Includes that before the training, CNN received a session from PAT diagnosis team for a virtual G6PD training to about 10 CNN lab staffs. And those lab staffs end up trained more and more lab technicians within the country, which was very helpful in the beginning. They got more used to how to do the G6PD test. And during the training, some trainers also identified hospital staffs who are trainees but more familiar with the testing process that can be the facilitators. And we also observed that a good and feasible ratio during the training within limited resources is when the trainer divided all the participants into groups, and 10 people per group per table, with 1 facilitator and 2 devices. So like 5 people will share with 1 device, and then 1 facilitator can monitor 2 devices at the same time. But if there are too many participants in 1 training and too many groups that cannot, because we have only limited facilitators, then the trainers will ask the groups to take turns and come to the front, to the table to practice, to ensure there is a good quality of practices. And each training have practices the G6PD test procedure for at least 2 to 3 times. In general, the observations would be more lab technician would be ideal to play as facilitators and could be more capable and have enough time to use the competency assessment to evaluate the trainees. Next, please. So for the quality control guidance for G6PD test in Cambodia, Health Center will conduct quality trips every month, and the future plan on an NCP lab to conduct additional quality control and supervision to selected health facilities are under discussion. And the eligible patients in Cambodia treatment guideline will be provided 14-day Primaquine, following with the revised threshold table that you can see here after the discussion by the technical working group, which is that for both males and females, patients with G6PD level higher than 6 units per gram hemoglobin will receive the radical cure. And the Primaquine in Cambodia is using the low dose treatment, which is 0.25 to 0.5 mg per kilo. And this decision that only people who are above 6 units of G6PD level provides a safer option for the treatment, given the TWG thinks that there is no enough evidence in Cambodia showing that male patients having G6PD level between 4 to 6, if they are actually normal or if they could be deficient. For the process, patients will be followed by BMW through in-person visit at the patient home on day 3, 7, and 14. Any side effect and adherence will be recorded into the MIS and paper-based, and BMW will refer the patient to health center for further check if any side effect happen. And if the patient checked by health center and have potential signs of acute hemoglobin anemia, health center will refer to the provincial hospital for further explanation. And the adverse drug reaction form by DDF will be filled in by the doctors in the provincial hospitals if any patient have been referred to there. Next, please. So following up the threshold table shown earlier slides, for patients who are eligible to receive the treatment, we have some initial distribution of the testing results from the practices during the training, which was 696 tests were conducted. Among all, 63% of the tests show G6PD level higher than 6 units, and 22% between 4 to 6, 14% less than 4 units. So one thing to flag here is the male patient having G6PD level between 4 to 6 will not be treated in Cambodia now based on the current guidelines, which CNM is also interested to collect more evidence to understand if this group is actually G6PD normal and if they are safe to receive radical cure. Next, please. So lastly, about the experiences and challenges until now we have learned for G6PD testing includes, first, some participants expressed their concerns about having different results when they're doing multiple testing, either during the same trainings or during the different trainings. Unfortunately, the data didn't track very well about if what would be the same trainees results with using the same ID. But we have captured 2 examples here for 1 male and 1 female, showing what kind of differences it was and how it will affect the corresponding treatment based on the guideline in Cambodia. And we actually don't know the reasons of the different outcomes for the same patient, but this may be able to partially resolve when the health center staffs have full competency to conduct G6PD tests without any errors. Next is about the high number of G6PD intermediate males, which in theory, they should not be existing, given the male's G6PD level is dichotomous. So next steps would be great to analyze the G6PD level of this group with a standard machine. And ultimate goal is to treat as many eligible patients as we can, but also safely. Last is about the guideline of quality control will also be implemented and revised as CNM keep conducting the national rollout, given the current monthly QC will consume more test strips used for control compared to the test strips used for the patient if within some low burden health facility. So a cost-effective solution with qualified test device at the health facilities will keep being explored. Yeah, I think that's all from my sharing for Cambodia. Thank you.
Great, thank you very much, Yichen. So now we're going to open it up for questions. I have some questions from the audience that were typed in the chat box. Again, you can either raise your hand or you can type them in the chat box. First, I'm going to get to these 5 that were from the chat. And we're going to try to stay on for about 10 minutes extra. So if you have time and are able to, stay on the line and we can keep getting to as many questions as possible. So the first questions are for Sarah and Laos. And it comes from Carrie about quality control. So what is the procedure if a G6PD analyzer fails a QC run? And also what percentage of healthcare workers pass the competency test after initial training?
Yeah, thanks for those questions, Carrie. The first regarding the QC procedures, it's similar, it's basically the same as Cambodia and Vietnam. So if it fails twice, then if it fails once, we check we go through the QC, so we do the test strip, and if we get the okay, we then run the test again, and at that point, if the controls are still out of range, then it's the same to contact a project manager and figure out what to do next. And then regarding the assessments, a percentage that failed and passed, I believe at trainings we didn't do the assessments, right? Mm-hmm. At trainings, after the training we didn't do the assessment. We only did it afterwards, right when they were starting implementation or before they started, and we haven't yet been able to go through and differentiate and figure out what their scores were. So we don't yet have an answer for that. We still have to translate some of the forms and make sure we figure out how to tally their scores correctly.
Great, thank you very much, Sarah. And then the next one for you is for the QC runs, would you consider them doing more often if the number of test samples were higher?
Yeah, I'll let Dr. Kill answer that one. Dr. Kill, they're asking if there were more PV cases, would we run the controls more frequently than once a week? You think? I mean, once a week is already pretty frequent, and that's in, and I think even if it's a high burden area, I feel as though 1 week would be enough. And then the question of whether we run it right before we have a patient is something that we probably wouldn't do just because of patient flow. So if the result, obviously they think it doesn't look quite right or doesn't quite match what they would think, then they can obviously run the QC and see hopefully that it's all functioning right, and then run the test again.
Great. Thank you. And then I have a question from Katie for you. So what is the significance of the challenge that you mentioned regarding the easy tubes that are used for mixing and sample collection? Is the problem just that there are not enough of them, or is the problem that they might be reused?
So yeah, the answer to that is both. There aren't enough of them in a box if we're running the QC frequently, but there is also the issue of using the same easy tube for both sample mixing and blood sample collection or sample collection.
Great, thank you. And so now I have a question for Huyen in Vietnam. This is from Katie again. So I wasn't sure I heard what you said correctly. What was the issue with the Bluetooth symbol? What was it covering up?
So actually, when they turn on the Bluetooth mode, the Bluetooth icon will cover the results of hemoglobin results. I will share with you later the pictures of this case. So when the Bluetooth icon covers the hemoglobin results, so people have facility thought that it is kind of errors, and they contact with focal point and inform that the analyzer is kind of like broken and no longer work. So does it answer your question?
Great, Katie. If you have follow-ups, just let us know. So now, Yucheng, over to you. I have a question. The question is regarding the challenge of inconsistency of results. Can you please clarify this? Is this an anecdote, or are you consistently seeing intra-observer differences? If so, are you going to investigate this further?
Yeah, thank you for the question. Yes, we don't really have data to indicate how much or how many people has this inconsistency results shown. But some of the concerns during the discussion of the training of trainers when they are getting tested and then saw different results, they worry it will affect people's confidence about the testing outcomes. So we will keep investigate this by collecting nationwide data through the malaria information system, because all the G6PD level and hemoglobin will be recorded into the MIS for the future. And those may be a better way to show if they have any inconsistencies that are observed, and also from the supervision to the health center level.
Great, thank you. Yucheng, one other question for you from David Roper. Was there any explanation given for the wide variation between G6PD results and HB results for the 4 replicates? I guess, David, tell me if I'm wrong, but I think this question is asking, did you try to provide any explanation to the healthcare workers?
Yeah, so for, oh, sorry.
No, sorry, yeah, that was my question, yeah. Thank you.
Yeah, so for that example, that male is actually a trainer, and then they were discussing about why this could happen, and because they are thinking perhaps pretty related to the skills of the health center staffs, that in the first 2 tests, they are just trying and start to practice. And then the amount of blood they take from the patient, and first is they say if they have wiped out the first drop of blood after they take the sample of blood, before they take the sample of blood. And then the second is if the blood and the buffer has mixed very well by the lab technician. And those details and tactics of the process when doing the test may affect the results. But that is like their conclusion and discussion about that, but we don't have any proof for that.
Great, thank you. So I'm doing my best to try to direct these questions, and if I miss one of yours, apologies, feel free to chat it again. But now I'm going to ask a couple questions to Pat. So I think we have Gonzalo on the line, and there's 2 questions. The first, how flexible do you think the manufacturer is to include easy tubes to improve usability and setting dates automatically? And the second question is from Ben Lay. Do you know how and based on what populations the current recommendations for cutoffs were established? The reason I'm directing this at Path is because I believe all groups are using the IFU and from the device. So Gonzalo might be best to answer that. But Ben, if you want other groups to answer that, just let me know and I can direct that question towards them.
So thank you. Thank you for the brilliant presentations. There's a lot of feedback in these presentations to give to the manufacturer. So we will definitely be sharing those, including increasing the easy tubes. And I know Spike's been working with a team to looking at reducing the number of units per kit as well. And the setting the date on the device. The instrument itself is going to be a little bit more tricky to modify, but definitely what the kit itself and what's contained within the kit, I think the manufacturer will be very amenable to taking this feedback, and this has been extremely valuable from that perspective. With regards to the thresholds, I think they have now been established based on quite a lot of data, including US, Thailand, US, Brazil, Thailand, and Ethiopia, and I think they're fairly conservative for the 3.9 or 4 units per gram hemoglobin for deficients will safely capture all deficient males and a lot of heterozygote females with low G6PD deficiency, so intermediates with fairly low G6PD activity levels. The 6.0 threshold is really, at least in quite tightly regulated studies, seem to be quite robust for people with 60 to 70% activity and above, or would it safely exclude most individuals with less than 70% activity.
Great, thank you. And now to Laos, I have a couple questions. The first one is from Germana, and it's asking a question about quality control, because I think there's some failed quality control results in your presentation. So how did the healthcare worker or lab tech feel when the quality control failed? Did they think that the biosensor wasn't working, or what was their reaction? So that's the first question. And the second is, what is the current thinking on how often you might want to redo training, particularly given the low case numbers?
Right. So for, I guess we'll start with the first question regarding the trainings. I mean, it depends how frequently you're doing the G6PD assessments too, because if you're doing those quite frequently, they get to practice it during that time and they get feedback during that time. So whether you do refresher training or the assessments, if you combine those two things, then I think if they get it every 3 months, every 2 months, one of those, either the G6PD assessment or a refresher training, that would be good, especially because for health centers or health facilities that don't have, for district hospitals, it's fine because their level of understanding is higher. But for health centers, if they really have no case for like 2 months, 3 months, then they're not, and they don't really look at the job aids. That point was very true, where you don't really look at the job aids, they just go from memory. Then frequent retraining is probably quite a good idea. What do you think, Dr. Kale? She agrees. Yeah. How about you, Sinkale? And then the first question was regarding the QC. I think that we don't really have a true answer to that question, because I don't think failed control runs have come at times when they're running them by themselves necessarily and then go on to test patients. But in general, there isn't much of a reaction to a failed control, right? I think there's still a trust in the test, which is good. I guess the question happens like if they run the controls and it fails multiple times, like at one of our health centers or the district hospital, we ran it like 4 times or 5 times, and just to see if we would eventually get results within range. And in that case, they might be more concerned if that happened that frequently. Whereas if it just happens once and then they get that result within range in the next run, then they're less likely to be skeptical of the device and the results.
Okay, great. Thank you, Sarah. Okay, so I'm going to ask one more question for Cambodia, and then I'll go on to a couple questions for Vietnam. So this is again from Germana. For Cambodia, did you try to plot the results of activities for males and females to see if the male distribution was bimodal?
Thanks for the question. Yeah, we haven't really tried this, but it will be interesting to see since we have some data from the training, and especially when we have more data from the national rollout, it would be more interesting and maybe more representative to see the whole country distribution.
Okay, great, thank you. And now two questions for Vietnam. So the first one is from Angela Devine. It's, did you collect data on the cost of providing training, i.e. cost per person trained or cost per training session provided? And then the second question is regarding the procedure for quality control, healthcare workers were instructed to repeat the control if the initial run was out of range. But what happened if the control kept being out of range? Were staff instructed to reach out to the national program? How frequently did this occur?
Thank you, Spike. So I think for the first question, yes, we did collect data on the cost of providing training. We haven't analyzed the data yet, but we collect the input data, for example, like how much does cost to buy, for example, like control and test kit for training, how many people per training session, or like other costs, for example, transportation cost to provide training, or like podium, some cost to provide lunch for training, something like this. So we will have that data available at the end of the study. For the second question, we instruct staff to reach out to a focal point at NIMPE, like national program, if the results of the second round of control run is in our range. For how frequent did it occur? So I don't have the exact number right now, but I don't think it happened frequently so far. I think that's one case. They contact the focal point NIMPE, and then the focal point NIMPE contact me, and then I ask them to check whether they turn on the control mode or not, and then they figure out that the result are out of the range because they forgot to turn on the control mode. And when they, I think they run again, I think it's in a range, so it's okay.
Great, thank you. And then I have the last question here in the chat box. Where is equipment manufactured, and how easy is it to obtain replacements or repairs? The device is manufactured in South Korea, but let me ask folks in Laos and Cambodia if they have any experience trying to get replacement or repairs, and if they could say if that was easy or not. So first, Laos, did you try to obtain any replacements or repairs, and do you have any experience with this?
No, we haven't. So if there's a case where we think the analyzer, something's wrong with it, we have a couple extra analyzers that we can just replace it with. So we haven't yet had to contact the manufacturer about it.
Great, thank you. I know in the study in Vietnam, at least it came with a 1-year warranty, but it'd be interesting to hear Cambodia, Yucheng, was there any warranty provided with the devices when UNOPS bought them? And then have you had to order any replacements or do any repairs yet?
We are also not sure about this yet, but we are following up with UNOPS about that since we are planning to develop an SOP for any repair process regarding, like, also related to how long the warranty, how to procure and replace the device. But we will let the group know if we have any updating information on that.
Great, thank you very much, Yucheng. So we are about 10 minutes over, and I want to thank everyone for staying on the line. If I missed any of your questions, please feel free to reach out to us and we can start to direct those questions to the right people. But again, thank you very much for joining the GORCoP today. Hopefully you enjoyed the discussions from Laos, Cambodia, and Vietnam. And please sign up for the next one. Looking to speak with you all soon and work together with you over the next few years on helping increase access to safer radical cure. Thank you, everyone.